I'm Dr. Anthony Tang. I'm a cardiologist, electrophysiologist with the Schulich School of Medicine and Dentistry at Western University, London, Ontario. The RAFT-AF trial is a randomized ablation-based atrial fibrillation rhythm control versus rate control in patients with heart failure and high burden atrial fibrillation. So the background of this is that from the last 20 years or so, there has been a number of really important clinical trials looking at antiarrhythmic drugs-based rhythm control versus rate control. We all were quite familiar with that, and by and large indicating that there is no difference between these two strategies of controlling atrial fibrillation, and that the rhythm control is not superior to rate control. In addition, it may be a little bit worse in some outcome measures. So I believe that most people would think that the rate control would be quite good in maintaining patients with atrial fibrillation. Then we ask the question, what happened in patients with heart failure and atrial fibrillation? The two coexist quite frequently. And up to now, there's really still not a whole lot of information that rhythm control is any better than rate control. The previously performed AF-AF trial was to look at this with antiarrhythmic drugs versus rate control, and really did not show any great benefit of rhythm control. And then more recently, in the last 10 or 15 years, the ablation come along with advancement in catheter ablation techniques, so that it's actually quite good in reducing the atrial fibrillation burden. So therefore, we lead us to think that, well, why don't we look at this with a more advanced rhythm control with ablation-based strategy? As it compared to rate control, would it be better? Simply to answer the question of if we are able to improve and reduce atrial fibrillation burden, and ablation probably can do better than antiarrhythmic drug. If that's the case, then is that still the paradigm of reducing the atrial fibrillation, getting rid of atrial fibrillation is a benefit to patients with both atrial fibrillation and heart failure? And that's the premise of this particular study. But we are also really interested is the patients with preserved LV function in addition to those who have reduced LV function. So that's the reason why we include those both type of individuals in this study. So the designer study is a randomized control trial of the ablation-based rhythm control strategy versus aggressive rate control strategy. And it was indicating that we have to have patients who have high burden atrial fibrillation. Either they have paroxysmal, but quite a significant amount of paroxysmal atrial fibrillation, or most of the patients have persistent atrial fibrillation. And also they have heart failure, not only determined by the symptoms of heart failure, but also by the fact that they have high NT-proBNP. The strategy for the two arms are that ablation-based rhythm control required, of course, that the patient needs to have an ablation procedure. But we also ask them to have at least one, but more than one, if at all possible. And of course, the patient has to consent to it. And only then, if they failed to abolish atrial fibrillation, and there's still recurrence of atrial fibrillation, that would they be allowed to have antiarrhythmic drug therapy? And here, the antiarrhythmic drug is restricted to amiodarone and dronedarone if necessary. whereas in the rate control arm, we will want to have a rather strict definition of rate control, and that is that the resting heart rate be less than or equal to 80 beats per minute, and the 6-minute hall walk heart rate would be less than or equal to 110 beats per minute. So we wanted to have a study that are clinically relevant. So therefore, we studied these patients with the primary endpoint of all-cause mortality and heart failure events. The heart failure events are defined as they were admitted to a hospital for heart failure and over 24 hours, or that they did not stay over 24 hours, but receiving intravenous diuretics or intravenous drug therapy in the outpatient basis, either in emergency room or outpatient clinic. And in addition, that they would have accelerating of their heart failure treatment, and that would be the outcome measures. What we found was that there was numerically less primary outcome in the ablation-based rhythm control arm versus the rate control arm. What we found was that the primary outcome of all-cause mortality and heart failure events was less numerically in the ablation-based rhythm control than in the rate control, with a hazard ratio of 0.71. However, the confidence interval of 95% was 0.49 and 1.03, and it really crosses the unity line just a bit, and with a p-value of 0.66. We also was pretty satisfied that the ablation has been good in reducing atrial fibrillation, so that we saw that the in the beginning, when the patients were in the baseline level, both groups of patients has over 80% of them were in atrial fibrillation, and in subsequent follow-up in up to 5 years, the atrial fibrillation, the patients with atrial fibrillation is much reduced to about 15%, no more than 20% level throughout the course of the study in the ablation-based rhythm control arm. And whereas in the rate control arm, the number of patients in atrial fibrillation remains over 85% and up to 90% level. We also look at those patients who have impaired LV function versus and the patients who have preserved LV function. The results of the primary outcome was somewhat different in the two groups. In the reduced LV function, and that is LVEF less than or equal to 45%, the ablation-based rhythm control seems to be doing better than those in rate control. Has a ratio of 0.63. However, the p-value is still not quite significant at 0.59. However, in the patients with preserved LV function, that is LVEF greater than 45%, the survival curves were not very much different from one another, with the hazard ratio of 0.88 and the p-value of 0.67. In addition, we look at some secondary outcome measures, and the secondary outcome measures is considered to be supportive of the primary outcome, and that the quality of life measured by Minnesota Living with Heart Failure, as well as AF EQT, will both improve more in the ablation-based rhythm control than in the rate control. LVEF improved more in the rhythm control than in the rate control, particularly in those with lower EF cohort. 6-minute hall walk, as well as the NT-proBNP, also goes in the same direction, and they improve more in the rhythm control than in the rate control. Well, the conclusion is that although the study was not able to find a statistically significant reduction in all-cause mortality and heart failure events with ablation-based rhythm control than with rate control, we think that numerically and all the secondary outcome measures are in favor of ablation-based rhythm control, particularly in those with LVEF less than or equal to 45%, which we would interpret it as that this is probably of clinical importance and that this deserves attention of the caring physician, and be able to perhaps use this strategy thoughtfully, particularly in patients with lower ejection fraction. This actually is in congruent with the CASO-AF study, which actually looked at patients with reduced EF who are also implanted with a ICD, and they found that ablation-based rhythm control was superior than antiarrhythmic drugs or antiarrhythmic drug rhythm control or drug-based rate control. Although the two studies are quite different in its design and the inclusion of patients, but the results seems to point towards that ablation rhythm control is of value in patients with both atrial fibrillation and heart failure with impaired LV function. I certainly encourage the physician to examine the results carefully themselves, but it does appear that with the literature and the RAFT-AF study would encourage people to take into consideration of ablation for atrial fibrillation in those patients with high burden and persistent atrial fibrillation and in heart failure. This deserves to be considered. However, one should also realize that there is potential serious adverse event with ablation. It is an invasive procedure. It should take into consideration of the potential downside or complication associated with ablation procedure, which can be serious. Well, for future research, number one is that for our study, we plan to extend follow-up for another 2 years, and we are in the process of doing that so that we have probably a better, clearer definition of the potential benefit of the ablation-based rhythm control. Number two is that there's still unclear in the literature about how to deal with patients with atrial fibrillation and heart failure with preserved LV function. We all know that those people are a bit sicker, a bit older, and more female, and they tended to have high recurrence of heart failure admissions to the hospital. So we need to find a better way of handling the atrial fibrillation in this patient. Whether ablation is the good treatment, then that deserves perhaps a bigger, more concentrated effort in the design of a randomized controlled trial. or that we may have to consider other means of treatment for these individuals.